So first of all, thank you for inviting me for this presentation. Just finished watching Dr. Pasares, who did excellent presentation, and I think we sort of a little anticipated that probably we'll see a good trend for better survival, overall survival, without really statistical significance. But just like I mentioned to my colleagues, I'm not going to change my practice. Afatinib is still my choice number one. Any patient with EGFR mutation goes into Afatinib, and it's been my practice for almost 2 years. I think all the major endpoints, progression-free survival, time to progression, overall response rate, and trend towards better survival are important endpoints, and making this drug better than first-generation TKI inhibitors. Well, again, all 3 or 4 major endpoints are positive. Progression-free survival, time to progression, particularly the trend when actually you treat patients longer, your PFS actually improves even better. That's the most important point for me. I prefer to treat patients with a drug which I know will be efficacious for a longer period of time than short period of time. So that's important to me. It will not change my practice. I think the fact that we have a trend for better overall survival is important to me, although statistically not significant. Again, progression-free survival, very important endpoint. Time to progression, overall response rate, those endpoints are important to me. Presentations, from the previous presentations, we know that actually both arms of the trial had very similar side effects, slightly maybe different on the Afatinib arm, but the rate of the side effects were pretty well equal, and discontinuation rate was 6% in both arms. So I have a patient on Afatinib who I reduced the dose to 30 milligrams. Actually, I have a couple patients who are on 20 milligrams, and they're doing very, very well for almost more than 2 years. So I'm very comfortable with the managing side effects of Afatinib. Some patients actually would need reduction of the dose, and it would eliminate majority of those side effects. Some patients would simply get used to those side effects. I'm managing them aggressively, and they're fine. I usually dose reduce when someone really has difficulty tolerating, so severe diarrhea despite my aggressive measures, severe skin rash, or liver function test elevation. You know, if I really have to do those things, but I usually wait first 4 cycles. I think overall quality of life improves because the patients do respond very well, 70% response rate. So some patients would have a better quality of life just because the symptoms of disease would improve.